Piquet, thanks for this very kind invitation. This is a very large and weird title that I want to try to answer. For the autoiliac disease, since the last 40 years, what such great numbers of progress we have made. And in France and in Europe, we have got some huge recommendations. Here are the last recommendations just written last year. This is, first, we need to use the barometer stent for iliac artery occlusions. Secondly, self-expanding barrier stent metal rather than balloon expandable stent, of course. And also it's recommended for task C and D lesions to use the covered stents. And also remaining for the patient at low risk, the surgical option. Thus, what is the best treatment? Is there only one strong algorithm? Frankly, I don't know. That's my only algorithm for all the endo procedures. This is the same. The first, this is to access, or from below or from above. Exactly, this is the case we have right now running. And after this is the cross, and we have made a lot of progress here using 035 or 18 inches guide wires with a specific support catheter. We made change during the procedures. And after this is to prepare the vessel with progressive angioplasty, long angioplasty in terms of length and in terms of timing to use maybe DEB also for the iliac, and of course the IVL. And after this is to treat, this is to maintain the artery open using CRAB or V-stenting or kissing, using covered stent or self-expanding. And you see here the list of questions we still need to keep in mind when we are proceeding during the case. Thus, I think for the autoiliac disease, the two main key points. This is firstly the quality of the outflow, I mean the CFA and the Prof, but also the quality of the aorta. Is there any choroidal relief? If it's a very long disease just starting just below the renal artery, purely this is for the open surgery. And also one of the key, is there some thrombus along the wall of the aorta that may be very pejorative for the permeability. We have seen three revolutions during the last years, of course, that have been mentioned by the excellent presentation coming from the first speaker. This is the crossing, and we have got tons and tons of different devices that are more or less indicated. The use of covered stent and also the use of the vessel using the IVL. This covered stent, we all know that it's very efficient. This is a mechanical barrier to the instant restenosis, risk of embolism, and moreover, the risk of rupture. Since the COBEST, we know that it's very efficient, and that will be presented in 3 days at CSA, that you have got in preview here. This is the results of the European study using the iCover, that is covered stents not delivered in the US, involving 5 centers. And here are the first results. Thus, the technical success is very, very good. Procedural success, there is no dissection, and here is the free from tear and free from tear and the primary patency that are excellent. The syrup that have been firstly reported by our friend Peter Goved, and this is an example of a syrup. Anyway, this is one or two cases. This is the first case using a covered stent, using iCover. This is a lady, quite obese lady, very autoiliac disease. This is the quality of the final aorta. You see the amount of calcium here. This is the ostia of the two common iliac arteries, and this is the previous CT scan. In that case, that is a very normal case. Thus, we use the syrup technique. And here, what is quite weird, we do not use for the aortic level the covered stent, but we use the nitinol stent that we use quite frequently versus the aortic covered stent, because we have a large stock of large nitinol stents off the shelf, usually dedicated to treat the aortic dissections. And here we use the IVL therapy, and after that we use the I-covered stent inserted in kissing into the previous placed nitinol stents. And, and after using the IVL, because no risk, no fun, we sometimes place the covered stent without any sheath protections. That was the case. And this is the results at 4 months, excellent results, perfect stent opening. But quite is very instructive here. This is the size of the two covered stents into the two iliac arteries. Maybe this is a little bit downsized. Thus, in such a case, no hesitations to re-intervene and to re-expand the two iliac stents if it's necessary, and according to the investigation using ultrasound investigation during the follow-up. Another example, this is a 62 years old woman. This is the angio CT scan for previous investigation. We have seen calcified lesion on the common iliac artery, calcified also lesion on the left CFA, and this is the stages here. You see the quality of the aortic bifurcations here and down to the CFA, and you see the aspect on the left side. That's what we have made in that lady. That was a surgical repair using a diaphragm bypass on the left CFA. And here, again, we use the IVL at that level to prepare after crossing the lesions on both iliac artery. After this is the predilatation. But you see here, with the IVL, we also use the ultrasound, and this is quite amazing and very instructive. You see each bit of IVL, you see a spray of calcium on the ultrasound. That is very, very impressive. You see here the spray of calcium, every bit of using the shock wave. After 10 cycles, we use a covered stent here. This is not a syrup, this is a casing stent using Bentley and eye covers. And what is also very important with the casing stent, this is to proximally flare the proximal part of the two covered stent here up, in that case, to 9 millimeters. And what we very frequently do with autoiliac reconstruction, we use a final cone beam CT to see the perfect re-expansion and the perfect opening of the autoiliac stent to see if there is any remaining compression or residual lesion. Thus, in summary, the treatment of autoiliac lesion has improved exponentially during the last 10 or 15 years. I think that there is no more limit, of course, after crossing. That is the main first point. Durability is under inflow and outflow quality. We have got very fantastic new tools that are available, especially for the crossing and after for the scaffolding and also vessel prep. But keep in mind, there is still a place for surgery, and I'm surgeon. If I've got an algorithm, I've got any algorithm, because I think that's what is the most important. This is to check and to study very carefully the angio CT scan before starting. We use all the devices and techniques at disposition. There is still a staff analyze. Of course, again, the crossing, the vessel prep using covered stent and self-expanding stent, especially down to the external iliac artery. And again, we use in most of cases cone beam CT and a strict follow-up of all those treated patients. And maybe, as you know, we use with some startups the AI, especially for the AAA, and to have an automatic segmentation that may give you automatically the volumes and all the different aspects using the cone beam CT. But with this automatic segmentation, we may also calculate automatically the amount of calcium, and we just publish it for the in the JET for the risk of stroke into the carotids, and also the risk of MACE for the calcium of SFA, and maybe to calculate automatically the amount of calcium for the autoiliac lesion. That could be a game changer for the strategy, for the technique, and maybe for the final results. Thank you for your attention.